Hello everybody and welcome back to Emergency Medicine Quest. In today's lecture, we will be discussing rhabdomyolysis. Before we begin, make sure to like, share and subscribe to the channel for more such content. We know that skeletal muscle is 80% water and 20% protein. And these cells require a lot of ATP and oxygen to do their job. So when rhabdomyolysis occurs, there are four things that happen to a muscle cell. First of all, the muscle is not able to either produce or utilize the ATP. Second, the oxygen, glucose, and other nutrients that are delivered to the skeletal muscle gets disrupted. Third, there is increased metabolic demand of the organism that the organism is not able to deliver. And fourth, that these myocytes itself are damaged. So now that we've understood that rhabdomyolysis is basically our striated muscle getting affected, we should know that it presents with a very wide variety of signs and symptoms. These patients can range from being completely asymptomatic to being really sick. The classic presentation of rhabdomyolysis is muscle pain, which is localized, stiffness, swelling, tenderness that is combined with a very dark colored urine. But this combination is rarely, if ever, found in patients. The most common presentation is just localized muscle pain or tenderness or weakness. And the most commonly involved area of the body is usually thigh, that is followed by calves in the back. How dark the urine is depends on what the severity of the injury is, as well as the patient's muscle mass, urine concentration, and the baseline renal function. That being said, if the patient does not have visibly dark urine, it does not exclude a rhabdomyolysis. And that is why when we have a patient in whom we suspect rhabdomyolysis, it is very important to find out the risk factors and etiology in that particular patient. So now let's go over some of the risk factors and etiology of patients with rhabdomyolysis. First risk factor that I'd like to talk about is exertion. Now this can be in form of doing excessive exercise, it can be in form of seizures or even status asthmaticus. Patients who undergo trauma, body temperature and an extreme change. So a patient presenting with sudden onset hyperthermia or hypothermia. Electrolyte changes can also induce rhabdomyolysis like hypokalemia, hypophosphatemia, hypocalcemia, hyponatremia. A patient who is septic or is infected with certain organisms can also develop rhabdomyolysis. Certain drugs like statins or other antilipid agents like ezetimibe or clofebrate, PPIs, psychiatric medications, alcohol, cocaine, all these and many more can also induce it. And then we have the others category like endocrine, like hyperthyroidism or hyperaldosteronism, or autoimmune conditions like dermatomyositis or genetic conditions. And hence why when we are suspecting this condition in a patient, it is important that we brush over these risk factors, ask them about in their histories. The reason why it is important to identify rhabdomyolysis in a patient is because of the complications it can have. So we will talk about its early complications and late complications. So first of all, compartment syndrome. Because most skeletal muscles are encased in a compartment, if there is a massive influx of calcium or sodium, it can cause a lot of fluid to accumulate in the myocytes, causing edema and hence raising pressure and leading to compartment syndrome. The second complication is development of electrolyte disorders. So we know that potassium is released from damaged cell, and what it can lead to is hyperkalemia. In cases where rhabdomyolysis is very severe with a lot of extensive muscle damage, calcium phosphate crystal can deposit in the damaged muscle, and this can lead to early phase hypocalcemia. So this hypocalcemia with this hyperkalemia can lead to very fatal dysrhythmias. Obviously, this is rare and has only been reported in a couple of cases. The next early complication is hypovolemia. So we know that the fluid moves from the intravascular compartment into the damaged muscle, and if the rhabdomyolysis is caused by muscle crush or electrical injury, then the fluid shift can exceed very large amounts, causing intravascular volume depletion. Among the late complications of rhabdomyolysis is myoglobin induced acute kidney injury. So we know that when a muscle breaks down, myoglobin begins to be released, and this concentrates along the renal tubules and precipitates in the acidic urine with uric acids, and it forms obstructive casts. Other than that, there is also a decreased production of vasodilatory prostaglandins like nitric oxide, which we know is a very potent vasodilator. So myoglobin, when it gets released from a damaged muscle, it acts like a nitric oxide scavenger. And obviously, when the nitric oxide decreases, there isn't much protection provided to the cells against oxidant injuries, and hence myoglobin causes damage to the proximal tubular cells because of oxidant injuries. The final complication or the late complication of rhabdomyolysis is DIC. Now we know that when muscle gets broken down, it releases a lot of prothrombotic substances, particularly thromboplastin. And although it is very rare, but theoretically, it can lead to the formation of thrombus in the capillary tufts of glomeruli and cause DIC. Moving on to diagnostic testing of rhabdomyolysis. So the definitive diagnosis is provided by serum creatinine kinase. So we can see in this graph that creatinine kinase increases in the first 12 hours after the injury. It peaks on the first 3 days and then normalizes for approximately 5 days. So any creatinine kinase level that is about 5 times more than the upper limit of normal confirms the diagnosis of rhabdomyolysis. Other modalities is testing of serum and urine myoglobin. So we just talked about how myoglobin is this protein that is basically broken down by the skeletal and cardiac muscles and is renally excreted. Now during rhabdomyolysis, myoglobin gets released by the damaged muscle and gets increasingly filtered at glomeruli. So when the serum concentration of myoglobin exceeds 0.3 milligram per liter and the urine threshold exceeds more than 1 milligram per deciliter, basically it confirms the diagnosis. And obviously, if we do a dipstick urine, then it is going to come across as positive in these patients because myoglobin is detected by urine dipstick. That being said, one can ask why serum or urine myoglobin not the definitive diagnostic modality? And that is because myoglobin has a serum half-life of 1 to 3 hours and it gets completely normal after 24 hours. Hence, it's an unreliable diagnostic test. And remember, if the patient does not have a positive plasma or urine myoglobin, it does not rule out rhabdomyolysis. As we already discussed that myoglobinuria causes a false positive result in urine dipstick, and that is why this is a drawback of doing urine dipstick when we're thinking about rhabdomyolysis. We can do other labs, and as we discussed earlier, we can expect electrolyte disturbances, so we can expect hyperkalemia, hyperphosphatemia. First, there is going to be a hypocalcemia that will be followed by a hypercalcemia. Hypercalcemia is because of mobilization of calcium that was initially concentrated in the damaged muscle. There will also be hyperuricemia from the release of muscle's nucleic acid, and this is commonly seen if the patient has a very large muscle mass. Often in literature, when we read about rhabdomyolysis, we discuss a really dark urine. Why is that? That is because the urine appears to be reddish brown in color due to the concentration of myoglobin and hemoglobin. Obviously, there are also a bit of bile pigments and porphyria present that contribute to the color. Moving on to the management of rhabdomyolysis. So the primary thing that we need to do as part of our ABCs is fluid replacement. We talked about how the complication of rhabdomyolysis is development of AKI, and part of rationale of hydrating the patients is to prevent the renal injury. So generally we start the patient on fluid restriction if their CK levels are 5 times more than the normal limit, and should be continued until the CK levels trend down and drop below the normal levels, which is about 1000. But bear in mind that over resuscitation is also harmful in such patients. So the ideal is to have a urinary output of 2 to 3 ml per kg per hour. We generally go for more balanced crystalloids like plasma light and lactated ringer as the fluid of choice. There is a theoretical disadvantage of using normal saline in rhabdomyolysis, and that is because normal saline contains NaCl. So if we are giving lots of normal saline, this can lead to a disproportionate increase in serum chloride levels, and that can actually worsen the acidosis, and that can in turn worsen the myoglobin precipitation. As per the latest literature, urine alkalization is no longer recommended, although this was classically done in the past with the help of sodium bicarb. But there have been lots of studies that have shown that there is no established benefit of alkalization, and sodium bicarbonate therapy has not been proven to be superior. About 20% of the patients are going to have their kidneys damaged in a very severe form from rhabdomyolysis, and they are going to end up needing renal replacement therapy. So as it is with other causes of acute renal failure, the indications for emergent RRT is if the metabolic acidosis does not improve, if there is a life-threatening hyperkalemia, or if there is a manifestation of uremia, anuria, oliguria despite. Rhabdomyolysis in itself has excellent prognosis if it is recognized and treated, particularly if it is treated early. Majority of the cases have a very benign course and resolve without any complications, but if complications develop and severe ones like DIC, then the mortality can be a little bit more higher. This brings us to the end of this lecture on rhabdomyolysis.